Hello and good evening. On behalf of CME Outfitters, I would like to welcome all of you to today's educational activity, Life Disrupted, the role of advanced practice providers in guiding patients with Crohn's disease through the challenges of bowel urgency. Today's program is sponsored by an educational grant from Lilly. Today's program is brought to you by CME Outfitters, an award-winning accredited provider for CME education for clinicians worldwide. This is a jointly accredited program by the ACCME, ACPE, and ANCC. As a reminder, please engage with CME Outfitters on X, formerly known as Twitter. There you can find more information about upcoming CME and CE opportunities, as well as healthcare news, updates, and more. So I am Kimberly Orlick. I'm a physician assistant who practices with Atlanta Gastroenterology in Atlanta, Georgia. I'm also the director of advanced practice providers for United Digestive, a large GI practice throughout the Southeast. I additionally am on the board of trustees for GAP and the chair of education for GAP, and I'm truly delighted to be here tonight, in addition to a distinguished panel of colleagues that I'm now going to ask to introduce themselves.
Hi, thanks. Hi, I'm Dr. Amar Nayak. I'm the director of the Inflammatory Bowel Disease Program and the founding partner of our new Midwest Digestive Health and Nutrition comprehensive digestive healthcare practice in Des Plaines, Illinois, and local locations in the near suburbs of Chicago, Illinois. I have been in practice for over a decade here, and a couple academic centers in the Midwest, and passion and taking care of IBD patients over the years, and have been pretty active in some of our national organizations, and very happy to partner together with this amazing team and talk about something very important, and looking forward to it.
Good evening, everyone. Welcome. My name is Susan Wolgamott. I'm a nurse practitioner in the Metro Detroit area, Bloomfield Hills. I work primarily with Scope Medical Group. It's a private practice in the area. In addition, I also work for the Clinical Research Institute of Michigan as a sub-investigator. I have been in healthcare 35 years. I started when I was 12. And I've been practicing full-time in GI for the last 10 years. I'm a founding member of the GAP organization, as well as expert faculty. I do medical education and consulting work for multiple companies and professional organizations. I am passionate about IBD. I see a lot of IBD in my practice. In addition, I've also lived with IBD myself. I've had Crohn's for the last 19 years, and my son has Crohn's as well. So this topic of urgency is something near and dear to my heart, and I'm very passionate and very excited to be here to talk to you about it tonight.
Thanks, Susan. Thanks, Dr. Nayak. So hopefully you all can understand why we're so excited to be here. I think we all have a real deep interest and passion for IBD and helping our patients. So to shift gears a little bit, I'm going to move into our 3 learning objectives for tonight. So the first one is to identify the contributions of bowel urgency, fatigue, psychosocial symptoms, and histologic and endoscopic healing, and the burden that all of these play in Crohn's disease and how they truly affect our patients' quality of life. Our second learning objective is to evaluate bowel urgency, fatigue, psychosocial symptoms, and histologic endoscopic healing for patients with Crohn's disease as part of the thorough symptom evaluation. And lastly, our third learning objective is to really engage our patients, and hopefully you'll really learn from us how to have this open communication and conversation with patients about these symptoms, including bowel urgency, fatigue, their psychosocial components of their disease, and again, the histologic, endoscopic, more objective healing goals that all affect clinical outcomes. So before the 3 of us kind of dive in and hopefully give a little bit of education and real world experience of Crohn's disease and urgency to Crohn's, I really want to kick this off by engaging all of you. And so my ask here is if each of you can do a quick audience poll, so you can see here the question of how often do you currently incorporate bowel urgency assessments into your evaluation of patients with Crohn's disease. And we are not going to show the results of this question right now, but at the end of this, we'll circle back and see how hopefully you'll be able to introduce some of the topics we've discussed here into your response going forward. right. So moving on, I think one of the things we all see very often is, unfortunately, for so many reasons, these Crohn's patients have symptom onset quite a while before they officially get their diagnosis of IBD. And so this slide really just points out a few highlights from the time the patient's symptoms start until they're officially diagnosed. And obviously following that, there's then, unfortunately, for many patients, the kind of long journey to getting on therapy and getting on the correct therapy, et cetera. But here what you can see is 8 months is the median time to diagnose a Crohn's patients. Beyond that, 1 in 10, so 10% of our patients have had symptom duration of 5 years before diagnosis. So we'll touch on a few of these reasons throughout, but I'm sure we all have seen this between access and referrals. And then if it's small bowel disease, that might be a little bit harder to find and diagnose, but really just thinking about those patients. And unfortunately, in many cases, how long it really takes them to get in to see us and then get that positive, accurate diagnosis. And now I'm going to hand it off to Susan to talk a little bit about, because it takes so long to get that diagnosis, what do we worry about in terms of the burden of the disease for our patients?
Thank you, Kim. So I guess what I'd like to do is a little bit tag on to the piece about this delay to diagnosis. Again, I want to highlight and point out that it may, this 8 months is medium time, to diagnosis, but it could take 8 months to get into a specialist. And I guess this was my biggest, hallelujah moment when my son became sick. So he's always been kind of an IBS-y kid, and he had, these symptoms for a while, but it became really prevalent this past May. And then by July, he was burning down. And had he not had a gastroenterology nurse practitioner for a mom, who knows how long he could have lingered in the system, going to the primary care doctor. And the primary care doctor might have said to him, well, you just have IBS, crummy diet. You need to clean up your diet and, eat more fiber. That'll make you better. But in the meantime, this poor child had endoscopic and histologic Crohn's from his esophagus all the way through to his TI. His entire small bowel was involved. And in the very short time it took us to get to a diagnosis, his albumin was down to 2. He had lost 57 pounds. Critical, serious complications. He could have also developed stricturing and penetrating disease in that period of time. These patients have, a twofold increase in the risk of need for surgery. Luckily, he doesn't have a lot of stenotic, type presentation yet, but he could have developed a critical abscess, perforation, fistulizing disease. We can see this, the delay in diagnosis will affect the UC patients as well, in that they'll have, the increased risk for colectomy if this doesn't get diagnosed in a timely fashion. So when we talk about, this piece of it, we're talking about the targets of what's important to the patients during this time. I mean, they're miserable with symptoms, and their quality of life is already affected on top of the stress and the anxiety associated with, what's wrong with me, and getting someone to listen and pay attention and validate what's going on. And these targets, resonate in the data that we collect as far as quality of life, and improving that quality of life is a top priority. And complete resolution of the symptoms, including that urgency and pain, stool frequency that we're going to talk about, and getting us to that point. So as we go forward, we're going to talk a little bit more about there's a difference between urgency and increased stool frequency. I mean, urgency is not exclusive of diarrhea. So when we're talking about urgency, we're talking about the symptom where there's the presence and the sensation that you need to have a bowel movement, and there's the urgency that you need to get there quickly because there's this constant looming threat of incontinence. Fecal incontinence is life limiting. The first time a patient, manages to make it to my office after their first accident in their car or at the kids' soccer game, it's absolutely emotionally, physically, socially devastating. So this is what we're going to focus in on tonight. And we're going to, further validate this. There's a study, the Confide study that was done. This is communicating the needs and features of IBD experience. This is the study that was done and taking a look at the different symptoms and how this related to, how they experienced their disease. So in this study, okay, we took a look at the diarrhea piece, the bowel urgency, and increased stool frequency. And these were the scores that you're seeing here represents whether they've ever had this symptom or they're currently experiencing the symptom. That's the blue and then the green. And they were comparing all patients versus patients receiving advanced therapies. So you can see, even patients that are receiving therapies are still burdened by these miserable symptoms at times. And that is because sometimes the symptoms aren't driven by disease activity. There are other features that can drive these symptoms, but regardless of the level of active disease, this feature of their condition is one of the most life-limiting features and the one that they want gone the most. So why don't you take it away, Dr. Nayak, and we'll talk about the rest of the survey results.
Sure, thank you. So the Confide survey, very important. I'd like to say this is a wonderful start to understanding how our Crohn's disease and ulcerative colitis patients suffer. And look, we have to simplify this. This is so complex. There's so many different types of phenotypes and bowel damage and things that can occur. And one of the I have basically two biggest goals that we can have in our IBD patients, right? I like to simplify it in that sense, is one, improve patients' health-related quality of life, right? And two, make sure that their life isn't shortened by the presence of this disease. Because right now, we don't have a cure yet. And I like to say yet, but we don't have a cure yet. So we have to improve our patients' health-related quality of life. And this delay in diagnosis that was kind of talked about earlier is so huge. And to me, and this is maybe a little different, it's about time travel, right? It's about us heading to, never having enough time, but always being asked to make some more. And, essentially you look at diarrhea, urgency, bleeding. What's the thing about urgency? We factor in time. We factor in not having enough time to get there and do a simple thing like having a bowel movement. This is what dominates patients and people's lives, right? In terms of that's all they think about. And this is just really proof, really, that this is among the top 3 most frequently reported Crohn's disease symptoms. Every so often in taking care of patients with this condition, we come to like an aha moment and a way to kind of figure out how our patients are doing better and letting us to, take care of them and more efficiently understand and kind of build that healing and feeling kind of gap and sync them together. And some of this really may be, hey, do you have diarrhea? Do you have frequency? A-holes, do you have any incontinence? But maybe you have a lot of urgency. And so some of these things, depending on the time of day that this potentially occurs, can be really, really transformative. And what we're seeing here is in the United States and Europe, right? We're seeing bowel urgency really reported as a large proportion of patients, both ever reporting it and even currently. I think both of them are striking, right? Essentially 6 out of 10 patients are reporting this. And as you're taking this survey of these patients, United States and Europe, we've got great access to medications, care, state of the art, and we're still having patients really kind of having this massive issue with bowel urgency and stool frequency and diarrhea, right? But understanding it kind of sandwiched in, linking both those things together, pouring gas in that fire is really, really important. So this is very valid and really transformative. And so thinking about this, if this being just as much an issue in Crohn's and ulcerative colitis, we may be used to thinking about, well, we have inflammatory bowel disease, we have ulcerative colitis, and we have Crohn's. And truly, we have probably a lot more complexity as is built into it. And our IBD patients can really, really kind of benefit from from understanding that, hey, I have Crohn's disease, I can still have that urgency. I still have this at least once a month and actually more frequently. And it occasionally leads to urgency-related accidents and really impacts the patient's ability to go about their life. And to the point of being that they're really, as much as IBD is an invisible illness, none of us can tell if anyone has IBD. We can tell if you have a Band-Aid on from a cut you may have had and get some sympathy, but you can't tell that patient, that IBD patient, struggling and all the things that they're doing underneath. Like they call that duck floating on that pond. And underneath, it's just how much effort it takes to actually smoothly cruise forward. You'll see this as much as IBD being invisible. You see patients and hear about them if you ask about patients wearing diapers, pads, other protective use to not soil themselves and have a lot of issues. And so really this occurs and is present in patients with Crohn's and ulcerative colitis. To challenge everybody who's here, ask your patients in clinic about this, and you'll find out that patients you may have known for months and years may have been struggling with this at one point, and it may not have been at the top of your concerns at that time. And so really impacting that quality of life negatively is a huge problem, right? So again, thinking about this in terms of time, you may have waited 4 hours to see them, but they may have waited 6 months and had urgency for many years, essentially prior to being even diagnosed with inflammatory bowel disease and getting on a therapy and a treatment algorithm that could help them heal mucosa, improve all these things, and even decline and decrease the amount of urgency. So pain, fatigue, we see this a lot in Crohn's disease. We may not even see diarrhea sometimes in Crohn's disease, right? Because we have classically rectal sparing. We may have patients who are having a bowel movement twice a day, but heck, if you're having that bowel movement twice a day at the worst possible time and you have to run to the bathroom, you may not capture that essence being like, oh my gosh, there's actually bowel urgency along with this. And so stool frequency by itself, any one measure by itself isn't perfect. Susan brought up earlier about just having small bowel Crohn's disease, right? You could have a normal colonoscopy, normal biopsies. Oh, you're fine, you don't have inflammatory. But no, and the fact of any measure is just as good as where you have to look at that clinically and attack all those things together, right? And the consequences of this are far beyond not having enough time to get there. It actually results indirectly and directly into things like PTSD, patients missing out on relationships, not enjoying the holidays, being afraid of what people will think, and having limited social engagement. We as humans are a social species that we kind of define ourselves by interactions. If we take that away from us, it really impacts things. We've learned this a lot in the last few years that we struggled through things, and think about what the IBD patient is doing all alone, not having anyone understanding what's going on with them. Really transformative and really an easy way to impact patients' lives, right? So in focusing on things that you can do to improve them, really this cycle, we talk about cycles of therapies that are ineffective. We talk about cycles of patients who are going to have urgency, fatigue, pain, and these symptoms worsen. And then patients come up and do crazy things because they sound crazily around, but that's what they had to do. They did what they had to do to get there. I've seen patients get up 3 hours before they have to go anywhere, knowing that they're going to have 6 bowel movements in the morning before they can even get ready and get on the road and deal with, gosh, we're in Chicago, deal with an hour commute. And so it's really impacts things that we can't do. And so this leads to further anxiety and gut-brain behavior, and even actually not thinking about this and even focusing and just healing the inflammation is even not enough, right? As we go to our treat to target strategies, we're going to figure out how to improve health-related quality of life and know that any one measure needs to be consistently measured over time. And so we really have a lot of things, a lot of work to do. And here's the problem, right? We need to get better. We need to get a lot better. I need to get better. We need to think about this amongst our time. So we got to stop thinking about, we have 15 minutes sometimes in some of our clinic visits to, we can't be like I go to save you 15% more in 15 minutes, right? Like you'd think about it, but we have to at least bring this to the forefront. If we're not looking for it, we're not going to find it. And the issue is that there's a disconnect because many of us as HCPs, healthcare practitioners, are not ranking this as patients that symptoms report, even though then when we ask our patients, they're actually reporting this. And so this is a way that we can get better and we can provide better care of understanding what the suffering is. And so we don't discuss it as much as maybe we think we don't know if we're going to be able to help and solve it. And certainly, I think we're finding out that we have ways to address this for pain, fatigue, and some of those patients that we can't really put a picture on, hey, not having that classic diarrhea with Crohn's disease really can be a big issue here. So remember,
I'd like to I'd like to chime in a little bit there, Dr.
Absolutely.
Nayak,
Thank you.
for one hot second. I guess I wanted to layer on to what you were just saying. This is one of my hard and fast truths that we know about IBD patients. Sorry to
And
interrupt your
Susan,
flow.
I think it ties right back to Dr. Nyack, right? He's talking about the
Yeah.
anxiety and the depression and the full circle. And I think we can all,
Absolutely.
Susan, you admitted you have IBD, but I think we can all put
Yes.
ourselves in the shoes if we don't have IBD of what these patients go through and worry about, and that urgency and leaving home and those social aspects of life they're missing, and knowing why that's driving this increased brain gut dysfunction.
Yeah, I like this. That's very real. I say, hey, we don't get butterflies in the stomach from eating caterpillars, right? And so, in that sense, these things are very real, and they're very, very real, and they continue outside of the clinic, and having that perspective and knowing about these things are so important. And you can't be more correct about how we define IBS as a syndrome. And gosh, guys, look up what those definitions are. That's IBD plus inflammation plus strictures plus damage. And so it's the whole enchilada, and if you can even tolerate some of that, right? And so honestly, it's such a big deal, and really important that we find out different ways. And this has been one of the exciting things, right, in the field. And us as a field, as IBD practitioners, are now thinking about things a little differently, right? I'm a huge sports fan, so it's like the NBA figuring out we can just shoot 3-pointers all the time, and we're going to score more points. Hey, we can actually think about this better, and then connect with our patients in a different way than we've connected with over the past previous years, right? And we've had this big revolution of, hey, we have to have this mucosal improvement and healing, and check therapies, make sure they're working, and so how is that? And so we have to monitor the therapy and monitor the disease itself, and so which gets complicated enough. There's these simple things, because of understanding something like urgency can happen without changes in stool frequency, right? Like, hey, you don't have diarrhea, you're only going once or twice a day. But then really looking at that, over half the patients have these urgency symptoms without change in stool frequency. And so you might have naysayers say, okay, I'll zag here and be like the negative answer. Well, you're never going to improve that. Well, I think we've proven that we can. And I think we have to set that bar higher. And yeah, do we have to improve it tomorrow or the week later? No, we have time, and we have to take advantage of that, and improve things slowly and get on that right path. So I think this is real. I think we have some exciting stuff here to show really, truly how it's really came out. I'll let you do some.
Yeah. I mean, we're going to definitely talk so much more about urgency and impact on patients' life and how we all can do things better. So before we move on to that next part of the discussion, we are going to share a clip from a real Crohn's patient, and just seeing one example. We know there's so many, but one example of how urgency truly impacted this particular patient's experience.
Hi, my name is Tina Swani Om Prakash. I'm the founder of the blog Own Your Crohn's, and the president and co-founder of the nonprofit organization South Asian IBD Alliance, also known as SAIA. I've had Crohn's disease for the last 18 years. I was originally diagnosed with ulcerative colitis in 2006, and 6 years later, that diagnosis was changed to Crohn's. Bowel urgency was a very significant symptom for me. Most of my disease in the beginning, especially, was rectal. I was really suffering from many accidents, was often wearing diapers, and a lot of times was having to use suppositories and enemas throughout the day. So oftentimes I was using enemas at night and suppositories during the day, and that actually helped relieve some of the tenesmus, that urgency to keep going to the bathroom. But really, it was quite significant, and it was very limiting in terms of quality of life. And I often, there is this shame that comes with it, psychosocially, especially when you're at work or when you're with friends, when you're young and trying to live with this disease. And you often feel like, okay, I just had an accident. I hope no one realizes. And so it was a very difficult thing for me to live with, come to terms with. And it sort of was just like, wow, why is this happening to me in my early 20s? Like, isn't this something that happens like much later in life? I did feel like I had to accept and work around bowel urgency as a real symptom. of this disease. It was one of those things where I felt like it was a limiting factor. I was often scared to drive or walk too much or run or do, daily living activities because I was like worried, is a certain position going to make me have an accident more readily than another? And it was just like I felt like I was always living on the edge of my seat. And I felt like if I didn't come to terms with it, if I didn't accept it, it would be that much harder for me, because otherwise I'd be beating my head against a wall saying, what is happening to me? So it's one of those things I had to accept. But I think, a lot of the medications did try to help with this, but they weren't a perfect fix for me. And that's one of the reasons why I have the ileostomy today, because the bowel urgency was just that bad.
So I think that video captured so much of what we spoke about and hopefully really highlighted that. Unfortunately, you can see here, this patient almost said, it affected her life so much, but she kind of had to learn to live with it. And I think this is a lot of that disconnect that Dr. Nyack spoke about we as providers don't necessarily know the importance and understand how high patients are experiencing and ranking the urgency in terms of how much it's affecting them compared to some of the other subjective symptoms that we might ask patients about. And so on that note, I'm going to shift a little bit into some of the commonly used indices that we might use to ask our patients about their subjective symptoms. And it's really interesting as we talk about this, again, just the disconnect between patients and what they find important and really affecting their quality of life and the things that we might currently be asking these patients about. So here you can see some of the commonly used Crohn's disease activity indices. And I'm sure many of you are familiar with some of these. And really, it just highlights here are 4 of the ones that are commonly used in clinical practice. And while these do focus on stool frequency and they focus on abdominal pain, none of these commonly used scales in Crohn's actually capture or ask questions at all about their urgency and their severity of urgency. So some even talk about extraintestinal manifestations. They talk about the psychosocial component, but again, no mention of urgency, which we just saw is one of the most common symptoms for our patients, and certainly ones that are truly limiting their everyday life. On the other aspect, and I think it's more common because of the rectal involvement and the tenesmus that we're used to asking about, when it comes to some of the UC indices, it's a little bit more included in some of these. So here you can see the simple clinical colitis activity index for UC, which does have a question specifically about urgency, where patients are able to rank that. Many of you also probably use Mayo subscores and things like that often do not include that. So really, hopefully by the end of this talk, we're going to continue to talk about urgency, but you can figure out ways to incorporate this topic that is impacting patients so much into those questions that you asked them and into really seeing if the therapy they're on is improving that symptom. So this is a great recent innovation. I don't know how many of you are familiar with this, but this is the urgency numeric rating score. And this has been published multiple times now, both with ulcerative colitis and Crohn's disease, and really showing that it is a great way to truly correlate patients' symptoms and to get a starting point for where they score their urgency, and another great way that we can really track patients' progress and if this really important symptom is actually improving. So as you can see here, it allows patients, again, subjectively to kind of report when you initially either see them first in consult, have that diagnosis conversation, that initiation of therapy conversation, and in addition to their bowel frequency, really start to ask them on a 0 to 10, what is your urgency now? And recently, what has been your worst possible urgency? And really open up this conversation with patients about urgency so that they understand that we as providers care about this and we really understand how much it's impacting them. And what you can see with some of the studies about this scale is it's validated, but it's also a great, reliable way to measure this patient outcome and their improvement in terms of urgency. And so at this time, I would love Dr. Nyack, Susan, I'd love to open this up and kind of share some experience about how you use this tool, how you've used a tool, how do you kind of incorporate urgency into your appointments with your patients? And I don't want to go into the total Q&A yet, but I already noticed we got a question kind of about, these patients come in, they have so many symptoms, they have so many things they want to talk to us about. How do you add this into that conversation?
Oh, that's great. I'll talk a little bit at this. I think this is a way that we can transform or help transform IBD care. It's the simple things. It's the at the ground level, really framing our patients, getting them ready, getting them these survey things. And we utilizing health-related quality of life measures, prior to clinic visits, or they can fill in. And many times actually over the years, I've said, patient one's really ever asked me this before. And I've had inflammatory bowel disease for over 5 years. And this is the first time anyone's even asking. And this, I haven't even met you yet. And some of those things can really set the things different and start the journey and that relationship really on the right foot. And I think this is just another tool for this, right? So I have lots of other funny comments of like, well, how do you remember this? How do I keep this? Well, it's like I butcher the score on purpose, but I like calling it the run score, if you will, RUNS. So we gotta go get the runs. Do you have diarrhea? No, but do you have the runs? So where are the runs? So that's where you have to get there quick because you got to run. So silly things like, but I mean that's how I've kind of tried to. One of the things that I've done in practice, and so, but it's really important, right? In kind of figuring some of these things out and trying to bring that part of the whole vernacular.
When I try to change up the conversation, with my patients, my approach has been, number one, acknowledging the second hard and fast truth about all IBD patients is they minimize their symptoms. They've learned to accept this. They've limited their life and accepted the fact that this is just the way it's going to be. They can't go to their kid's soccer game. They can't go to a theater. They can't do this kind of stuff. But right off the bat, validating and acknowledging that and asking deliberate questions like, how many times per week are you saying no? Are you changing what you want to do or saying no to social engagements because of your symptoms, not because of your disease? I'm changing the conversation because of your symptoms. How are your symptoms limiting your quality of life? I have abandoned all concepts of walking in that door and saying, how are you doing with your IBD? How are things going? Are you okay? Here's your refills. That is not in my vocabulary anymore. We need to be fierce advocates, whether we use a tear-off tool or some sort of qualitative or quantitative measure. We need to validate for these patients that we hear them and what's important to them, what's limiting their life and their quality of life. So that's hard and fast truth number two. All IBD patients minimize their symptoms. So we have to open up that dialogue and let them feel validated that this indeed is driving their quality of life.
So helpful, Dr. Nayak. I'm going to use that runs one. And Susan, I think you really validated what this patient shared, right? She said, I kind of learned to live with it. So they accept it. And I agree with you. I think all of our IBD patients remember when they were their worst. And even if they're not great when we're talking to them in the moment, they're better than that worst moment. And so they really do downplay their symptoms because even if they're just a little bit better, they're better. And we'll certainly come back to this. So I'm going to shift gears again, and let's review a case that I think will probably highlight patients that many of us see similar to Margot. And hopefully we can kind of talk through this and open up this conversation a little bit more. So Margot is our 25-year-old female. She is coming in for her 3-month follow-up, which is just her regular medication review check-in. So she was diagnosed with Crohn's 2 years ago, previous resection for Crohn's. She had CRP and Calpro 6 months ago, as well as a normal colonoscopy 8 months ago. She's on infliximab 5 milligrams every 8 weeks. And now she comes in today and she notes bowel movements 3 times per day, nocturnal bowel movements once to twice per week. So this patient gives us some statements. I have a lot of days where I feel like my symptoms are taking everything out of me. I feel tired from having to wake up at night. I haven't been able to make it to the bathroom in time twice this month and have started to carry extra clothes with me. So we touched on this, right? All these symptoms don't always equate to active IBD. Susan, you did a great job. We talked about IBS. There's a lot of other overlapping conditions we can see with our IBD patients. But let's talk a little bit here about Margot. We see this patient like Margot, and I'm curious, Dr. Nayak, Susan, kind of first response to this patient, again, 8 months ago, 6 months ago, objective biomarkers are normal, but she's sitting in front of you and nocturnal stools, urgency, nocturnal stools, exactly.
Nocturnal stools,
Talk to me
number
about
one.
it, Susan.
That was the first red flag. Her disease is flaring. there's no question. No question.
I agree. So nocturnal stools, I think great call out for everybody, right? We know when we think about IBS, alarming symptoms, nocturnal stools on that list. This is not something we typically see in our non-IBD patients. So nocturnal stools agree. And she's here telling us it's affected my quality of life. All of our patients don't do this. This is an easy patient who could come in and say, I just need my meds refilled. And the provider could easily say, CalPro CRP, check the box, stay on meds, see you in 6 months.
The other thing that, Jim, the other thing that jumped out to me though too is, and I think that the people at CME Outfitters, the Casey that we were working with, bringing this presentation together, did a beautiful job of really painting this picture with this patient, talking about this. And it's hard to describe to someone who doesn't live with it. I know what it's like, but this vague overall, the disease is sucking the life out of you feeling. It's almost flu-y, kind of yucky, fatiguey, tired. She already painted that picture fairly well. And that's another red flag for me, that there's something brewing. This is definitely, we've got underlying disease activity that's starting to fire up. So.
Well, yeah, I mean, Susan just said the F word. I mean, fatigue is the F word in IBD clinic, right? Like that's the F bomb. That's the one that matters. That's a sign. And let's say like your patient's in front of you, they're telling you you're not doing well, but I'll zag here a little bit. So look at this. Let's talk about this patient. Look what she's gone through. So there's this concept of disease severity and disease activity. She's 25. You guys remember, think about when you're 20. She's 25. She's had an operation. She's on a advanced therapy, infusional advanced therapy, and she's had an operation, right? And she's young. And she's had stuff that looks okay, but she's still not feeling well. That's like something's up. And the other thing is that concept of time, minutes, hours, seconds, weeks, years. We have to be time travelers I love time traveling, but we have to say, okay, when was that? That was 6 months ago. Okay, well, that was 8 months ago. And now you're here for a 3-month follow-up. So there's actually already been a visit after that 8-month colonoscopy. And now you're here for the second one. So organizing these things out, knowing that at that snapshot at any one point in time, let's say there was even a CT scan and an MRI done. But even if it was done that long ago, we have to keep those things in perspective, that this condition changes. There may be other changes that she went through during that time period. And that concept of you may just be catching it, just getting lucky enough that's there and catching things right when they're about to start, right? And so keeping in mind that knowing that, hey, her disease has proven that it can be raging, requiring an operation. We must always think about those things together and then think about and investigate those symptoms. So that was kind of what I kind of lifted from this.
Huge, Dr. Nack. I mean, I think that's a great call out, right? We know the risk factors for disease severity. So I think it's great. We called out this young patient. She's already on advanced therapy. She's already at a surgery, right? So this is somebody we really know is high risk of severe disease, complications, recurrence of disease. Susan, I'm going to hand it back to you. Maybe you can enlighten us a little bit more about all the other factors we think about in these bowel urgency Crohn's patients.
So I know that our video clip, she brought up one really important component. So Crohn's, we often recognize, validate, acknowledge that in the UC patient, they always have distal disease. That's the nature of UC. Starts at the anus, moves its way up. But not all Crohn's patients have significant rectal involvement. Those distal symptoms really drive a lot of the tenesmus and urgency type piece, and that plays into the anal rectal dysfunction portion, whether it's neurologic or physiologic or disease activity. If there's impairment in the way that the bottom can control that stooling, that is a major feature. Now, if you've got, a female Crohn's patient, maybe there was significant obstetrical trauma at childbirth. And I tell my patients all the time, I say, children, God love them, but they're the gift they keep on giving. Here it is, 20 years later after you delivered that 10-pound baby, and lo and behold, now nothing down there works right anymore, right? So if you add to it some inflammation and maybe the stool consistency, a factor. We also know that Patients can suffer from other physiologic complications, pathophysiology, maybe they lost their gallbladder in the process of their lifespan. So now you've got the feature of bile salt malabsorption adding to this. One thing that's not listed, well, dietary components, I guess it goes under, but I don't know very many IBD patients where salad is their friend. Okay, there may be dietary components that fuel some of these symptoms. Intolerance, lactose intolerance, that's a no-brainer. All adult humans are lactose intolerant. If I give an adult human enough lactose, but definitely if I give an IBD patient enough lactose, that's going to be a component. So there could be dietary components. Dysfunction of the brain-gut axis. Okay. Most often we attribute this to the IBS overlay or the IBS features, but when the connection, this is what you're talking about when you talk about a patient with a nervous gut. Every time they have to take a test or they're having stress at work or family issues, and they feel it right in their gut, and that stimulates that need to go. If there's inflammation, active inflammation that's brewing, in the gut or outside of the gut. And then there's EPI. And we deliberately added this into this, even though you don't necessarily see EPI directly related to CD. But keep in mind, patients with CD will sometimes have other medical conditions like diabetes that could increase their risk for EPI. They could also have comorbid autoimmune pancreatic disease. Perhaps maybe that gallstone that caused them to lose their gallbladder, took off at one point and injured their pancreas. There could be several factors here. So if they've got comorbid EPI as well, which could easily get overlooked for a long time as a driving feature, if you've ruled out that the inflammation isn't there, we don't have any Crohn's disease activity, their gallbladder is still intact and they're still pooping their brains out, they're losing weight and their albumins are dropping, something's going on. Looking for something as simple as EPI as a feature that's driving the malabsorption, the diarrhea, even the urgency and incontinence. So we'll go into this next slide here and talk a little bit more about kind of the treatment paradigm when you're trying to sort this out. Okay, so if you've got a patient and it's their primary complaint, they've got some diarrhea and or urgency, one or the other, if they're an IBD patient that's established, is that inflammation under control or not? Do we need to tune up that? If it's under control, so what else can we do to make things better? So everybody, let's, kind of chime in and take a look at this. I have kind of my own way that I do this, but it's really pretty much on track for what we see here. There, depending on what we seem to see what's driving their features, we kind of go in different directions. What about you, Dr. Nayak? How do you attack this as far as the pharmacologic, non-pharmacologic?
Yeah, no, this is a great way to kind of think about and work through this, right? And how to incorporate, treatment and diagnostic algorithms. I think a great first question when this comes up is just to say, hey, do I have evidence of active inflammation currently? And I think it's very important to be careful about that so that your patients understand. I think I've probably been a victim of some of this too. It's like, oh, well, it's like, well, your calprotectin was normal or that CRP was normal, which remember, nothing is perfect. CRPs can be normal about 30% of patients with active inflammation, where their colon looks like something from Arby's on the inside. No pun, no harm, just picking a thing here. But so we have to actually say, hey, is there inflammation or not? And if there's inflammation, then we have to have that conversation about whether or not their current baseline maintenance treatment or their rescue treatment is actually being effective, right? And so that concept of anorectal dysfunction, patients with active inflammation in their colon and their rectum will have an element of anorectal dysfunction. And so looking for some of those things. So it's addressing and assessing for active inflammation is a great first line. But just because inflammation isn't there and they have those symptoms doesn't mean that we're off the hook, because they're not. And we have to then go back, put our caps on and say, okay, well, get the time of this. How did this occur? When are some of these other options, right? Are there issues with anti-diarrheal overflow, pain, discomfort? Has there been dietary indiscretion or contributions to this? And so I think then looking at other interventions and kind of making a semi-personalized plan. It's like, well, we have these ways to look at it. Which one or two things we want with, let's try it, and then back and follow up and see how. That's the one thing, right? That's the other F word. Follow up and see what the actual interventions, how well they work. Sometimes we do some of these interventions and see them 6 months later for their next med refill, and then they tried it for a week and nothing ever happened. Let me know if it worked. Even if it didn't work, you're not bothering, and then come out and have a targeted way of saying, okay, let's move down this line for you. Let's look at other strategies, calling other teammates, like our psychosocial support, our pelvic floor rehab patients, right? You talk about obstruction complications in males and females, and males even can have this as well. Pelvic floor, anorectal dysfunction, and so forth, right? And that brain gut thing you spoke about is so real. It's such a big, important part. And sometimes it's difficult and challenging to describe it. But one of the things that I use, many patients, people now wearing these heart rate trackers, but their brand of phone or watch that they're wearing, and you can get on your cycle or walk and get your heart rate up, and that's a physiologic response everyone understands. You have tachycardia, elevated heart rate. I'm sure that there have been times on the holidays or your birthdays, or you're happy or anxious, and you can get your heart rate up, and that's a physiologic measure just by the state of what we're thinking and feeling. And so our body can then understand, and many people can then understand that your gut is actually probably more connected with your brain than your heart is, in that sense, right? And so that concept and that understanding of these things can make a little bit of it. But to wrap my old longer thing up, I think first making sure the degree of inflammation is present, the degree of it, how long it's been there, addressing that, and then looking at all the other things together, I think can be a big role here.
Another thing that we neglected to really put on here, and I guess it really is an important piece when I'm assessing a patient in this situation, is there the possibility of an infectious etiology as well?
Mm-hmm.
These patients
Yep,
tend to be
points.
vulnerable to that. They tend to be very vulnerable in those situations. So piecing out that as well, if there's an infectious etiology that's driving part of this, I tend to, try to drive down to what I think is more likely driving their symptoms before I decide on a treatment, of course. But almost always these patients will have, more acute features, phases, and then more, intermittent, low-lying, everyday features. So if they're the person, for example, that most of the time they do okay, but when they get stressed, they get, a little crampy and the urgency comes up. That might be the patient that I'm using the antispasmodic for, that they can use as needed. But if they're always anxious and they're not getting a lot of sleep, and that may be the one that I choose to do that tricyclic antidepressant to interrupt that dysfunctional pathway between the brain and the gut that's driving those features. And it helps to kind of raise that threshold that it takes to tip them over into that spastic, irritable, urgent state. Binding up the bile acids, diet and lifestyle features. Believe you me, you can shovel as much fiber as you want into these patients. It is not going to fix them. It is going to bloat them. They are going to be miserable, but this is much more sophisticated than that. And each one of these patients is going to be very unique. Their phenotypes are always incredibly unique. And you have to, like Dr. Nyack said, drive down and individualize that care. Kim also mentioned this as well, making this very customized to that very individual person and which piece. In fact, I think Dr. Nyack brought too, Kim mentioned how they come in and they've got all these symptoms and all these complaints and all these concerns. What I do with those patients is, okay, what are the top two things that are bothering you the most? What's limiting you the most? And almost all the time, it comes down to urgency and stool frequency. So
Thanks, Dr. Nyack. Yeah, Susan. So I mean, I think the biggest takeaway from you too, and I'm in agreement, is number one, we need to figure out, is this active IBD, active inflammation? And then number two, we need to tailor it with a great history and think about that patient sitting in front of us, individualize what are their risks for EPI, what is their level of brain gut dysfunction that might be driving IBS, and then really individualize therapy based on that, which is so helpful. And I hope helps everybody with a few takeaways from this. So I'm not going to lie, I'm pretty excited. We're going to revisit the audience poll now from earlier. So initially I'd asked you guys to think about how often you were incorporating bowel urgency assessments into your evaluation of Crohn's patients. Now we want to know, how often will you incorporate bowel urgency assessment into your evaluation of patients with Crohn's disease? And this time exciting, we're going to see some results. Okay, so thank you to everybody who took that. I think it's great to see that hopefully a lot of providers are really going to start to incorporate this into their conversation with patients. We can use the run scale, as Dr. Nyack called it, but at least have some tips of how to start to think about doing this. So to finish with that, I think it's really important that we just offer some SMART goals. And if you've never heard of SMART goals, these are specific, measurable, attainable, relevant, and timely goals. And I ask you to kind of take away from this presentation, how can you use a SMART goal to increase the percent of patients with Crohn's disease that you're actually screening and having this conversation about bowel urgency with, and really trying to improve the amount and number of patients with Crohn's who identify personalized treatment goals for addressing these symptoms that we know truly impact their daily life, including bowel urgency. So again, we talked about that urgency numeric rating score. I'm going to call it RUNS from now on, but I think the big takeaway from this is really thinking about how you can incorporate this and these conversations into SMART goals in your everyday practice with your IBD patients. Now with that, I know that there are a lot of questions that have been brewing. So I'm going to try and go through these questions. Dr. Nyack, Susan, call on you to kind of help us lead some of these questions. So first one, great one. So there's a couple that kind of go to work accommodations. So what kind of accommodations do you recommend to have for our IBD patients who might have to work in an office environment? And as a follow-up, patients often seem uncomfortable disclosing their IBD to their employer. So how can you tell if discussing with this employer will help or hurt, or how do you have these conversations about accommodations with patients?
Right off the bat, I validate for that. Right off the bat, I reinforce that IBD is a covered condition under the Americans with Disabilities Act. These employers are required to accommodate. And it's a tough conversation, depending on the situation, if they're afraid of any kind of retaliation. I've had multiple patients be fired regarding, their toileting needs. I've written many letters. So first of all, the first way that, and then the second piece is offering to help them do an intermittent FMLA, so that if they are in a bad flare, they've got something to fall back on where they can take the time they need to deal with their flare symptoms.
I'm going to go to
Dr.
Oh, sorry, go Dr. Nyack.
Yeah, no, so that's really important. I think being supportive of that is crucial. Even for our adolescent patients. I don't know how many letters I've written to college professors and kids in class. I'm like, hey, I need to use the bathroom, and they won't let them go. And that's been a common one for me over the years. More so, it's been less recently, but certainly these we have to support our patients, and we have to support them in those things. Intermittent FMLA is great. I think getting that sense of just having a conversation about it, like, hey, I need this, and okay, well, what for? Well, how can I help? What's going on? Figure out how you can help support them. I think is really important.
So I love this question. This came from somebody who works in an infusion center where they do administer medications, including infliximab. And they said sometimes the docs come in during infusion, and sometimes the providers don't see the patients. So what can these so helpful, nurses, infusion staff, how can they ask questions, and what questions are most important for them to ask these infusion patients when they see them that day of the infusion?
Well, I mean, I can start with that, but I think I mean, they have such a great patients over the years and months have such great relationships with their infusion team. Probably sometimes seeing them more than their GI clinic practitioners, arguably, right? And so they can do a lot, and they can just be an advocate for the patient and be like, hey, how are you doing? Are you feeling okay? What's going on? Oh, this is going on. Oh my gosh, things are go. You should talk to someone about that and see if things can be okay. I think just encouraging follow up, encouraging communication can go miles and miles and miles.
To expand on that, having some sophistication regarding those questions and knowing about some of the red flags. So not, how's it been with bathroom issues? Is the urge to have a bowel movement waking you out of a sound sleep? Are you having any accidents, any blood? What about fatigue? Are you sleeping well? Are you able to eat okay? Or are you restricting, the next piece to that? Are you having to restrict because it causes pain or makes you stool too much? Or, um, this is an opportunity too. They all get weighed. They all get weighed on the way in. And if you see a big change in their weight, that could be a red flag too, because that could mean that either they've been on steroids, or somebody put them on steroids and they've been eating everything that's not nailed down, or they're losing weight because they aren't able to eat because it's either triggering symptoms or causing pain, especially in Crohn's patients. That's a big red flag. More so than diarrhea or urgency. If they're having bad pain with eating, that's a big red flag with the Crohn's patients. So I think it's a beautiful thing. I have to echo what Dr. Naik said too. The infusion staff is critical. They have beautiful relationships with these patients. They spend hours with them, especially in infliximab. It's a 2-3 hour infusion. They develop that relationship, and they can really keep tabs and ask better questions. They have more time to ask questions than we do. So I think it's a beautiful thing.
So, Susan, Dr. Naik, I think we touched on this a little bit, but there's a question directly about if it seems evident that the bowel urgency is being triggered more by stress than their active disease, what are kind of your tools to help manage their stress, whether it's pharmacologic or non-pharmacologic tools?
I've been lucky over the years to develop great working relationships with health psychologists that have been able to really kind of help kind of get to the core of some of these considerations, which are huge, and it's been transformative in terms of being able to figure out certain ways to kind of relax, understand what they're going through, and then develop some other strategies as well. And along with them, we've had a nice collaborative relationship where when there's a potential avenue for certain neuromodulatory type medications to help with stress and anxiety and depression, they can be taken very safely within inflammatory bowel disease and along with inflammatory bowel disease medications. And so having that kind of throughout period is important. I think having a little bit of comfort with potentially prescribing or someone on the team being comfortable prescribing that, I think is important.
I'm going to do one last one. Sorry.
To add to that very quickly,
really bad on time.
Yeah,
ahead,
just quickly to add to that, layering in some sort of rescue strategy so that they can have confidence in the insurance, so that they know that they can have a way to rescue. So anyway, yes, we're getting tight on time. Go ahead, Kim.
I know. And I know there's a question about CME, so I want to make sure everybody gets an opportunity to receive credit for CME. I'm sorry we couldn't tackle all the questions due to time, but to receive credit for CME, complete the post-test and evaluation online, and then you can click on the tab to request credit. I want to thank so much, Susan, Dr. Nayak, all of you who were able to join us tonight. I hope this was helpful, and I hope you learned a few pearls and smart goals that you can really bring into your day-to-day clinical practice.